Hi, we're from PBL 9 and we're going to present case 1. And this is the case.
The complete diagnosis for this case is diabetic ketoacidosis due to type 1 diabetes mellitus.
Alright, so one of the investigations that we can do to diagnose Miss A's case is that we can do an arterial blood gas, which is known as ABG. So what does this ABG does is where it measures components of your blood such as your oxygen levels, your pH value, your carbon dioxide, and also your bicarbonates. So since Miss A presented with a pH value of 7.1, so it indicates that it's acidic, and the normal range for pH value is around 7.4. And Miss A also presented with a bicars value of around 12 millimole per liter, and the normal range should be around 25 to 30 liters. So this is because the ketone body is very acidic, so it accumulates in a very uncontrollable diabetes, causing metabolic acidosis because there's low pH and also low bicarbs.
The choice of anti-diabetic agent for her after discharge from hospital is the basal bolus insulin therapy, which is for the basal, we'll be using long-acting analog, which is glargine and determine, and for the bolus, we'll be using a rapid-acting analog, which is lispro.
Since type 1 diabetes is a condition where your body attacks your own pancreas, hence your pancreas cannot produce enough insulin, so insulin must be administered for the patient. There are two types of insulin that can be given. The first one is the basal insulin, which provides steady release of insulin throughout the day, mimicking the body's baseline insulin production. And the second one is the bolus insulin, which is administered before meal to address the surge of blood glucose after eating. Its doses can be adjusted depends on what you have eaten. And insulin provides flexibility in adjusting doses, and it is more physiological, and it can also reduce the risk of hypoglycemia.
So what are the other important issues that need to be addressed with this patient? First of all, we need to start insulin therapy for her, and then we should teach the patient on injection techniques, timing, and schedule so the patient can self-inject if necessary. Next, we should educate the patient to recognize symptoms of hypoglycemia, and we should educate the patient and her family members about diabetes mellitus by providing them basic information on self-care for diabetes, as well as simple info on diabetic diet, such as carbohydrate counting. Self-monitoring of blood glucose should also be performed via glucometer, ideally 4 to 6 times a day, and more frequently on sick days and on exercise. We should also watch out for hypoglycemic symptoms such as dizziness, hunger, tremor, confusion, and seizures, as well as hyperglycemic symptoms such as polydipsia, polyuria, dry mouth, nausea, vomiting, abdominal pain, and shortness of breath. We should also manage any complications of diabetes mellitus, such as neuropathy, which may cause diabetic foot ulcers, vasculopathy, nephropathy, and retinopathy.